Welcome, I'm Janak Goyal, and in this section I will review some images of sonographic pathology of ankle and foot which I have seen in my practice. Now here is an image of an ankle joint effusion. If you look at this image, the image shows an extremely distended ankle joint capsule, and here is your tibia, and here is the entire ankle joint capsule attaching to the neck of the talus. And what you see some anechoic and some hypoechoic areas indicative of a complex effusion. And the differential diagnosis of a complex effusion includes infection, hemorrhage, inflammatory conditions such as rheumatoid arthritis, crystal deposits, PVNS, intra-articular air, and synovial osteochondromatosis. And aspiration of this joint and examination under polarized light microscope showed needle-shaped negatively birefringent crystals consistent with gout. Now here is an ultrasound image of a patient who presented with ankle and foot swelling. My clinical impression was the ankle joint effusion, but the sonographic examination proved that my clinical impression was wrong and the patient had an isolated effusion of the talocalcaneonavicular joint. In this triangle you see this, here is the talocalcaneonavicular joint and the effusion projecting towards the tibiotalar joint. Now, blind palpation guided aspiration of this joint, inserting a needle into the tibiotalar joint, would have missed this effusion and resulted in a dry tap. This 54-year-old woman with the swelling on the dorsum of her right foot was sent for evaluation for possible gout or septic arthritis. The ultrasound examination showed a fluctuant swelling with a positive power Doppler signal, and here you see the compression and the fluctuation of this swelling indicative of a subcutaneous abscess and the normal appearing joints of the foot deep to the abscess. The palpation guided blind aspiration of the joint through the abscess would have planted the infection in the joint and resulted in a bad clinical outcome, which was prevented with the proper in-office use of ultrasound. Here is this 40-year-old man with pain and swelling of right ankle for 3 weeks, and the sonographic examination showed an isolated effusion in the peroneus brevis tendon sheath. The short axis of peroneus brevis, peroneus longus, and here is the long axis of peroneus brevis attaching to the tuberosity of the fifth metatarsal bone, and here the effusion on the peroneus brevis tendon sheath. Here is one of my patients with long-standing rheumatoid arthritis. She has been on multiple medications including biologics, methotrexate. She's a 48-year-old woman. Now she comes in with isolated pain and swelling of right ankle for 3 weeks, and the sonographic examination of this patient showed an isolated tenosynovitis of the peroneus longus tendon sheath. Here is your brevis, which is anterior, and here is your longus, which is posterior, and here is the long axis of the peroneus longus on the cuboid bone crossing deep into the foot. Let's look at the Achilles tendon, and let's look at the multiple kind of pathological lesions which are encountered in the Achilles tendon. And here is your Achilles tendon, shows a hypoechoic and anechoic lesions in the Achilles tendon at the attachment, and the Achilles tendon is thickened at the attachment. And here is the short axis view of the Achilles tendon, similarly showing a different kind of lesions which are some hypoechoic and anechoic lesions consistent with Achilles tendinopathy and tears within the tendon. And here is another patient who has a tophaceous gout with a huge tophus sitting on the posterior aspect of the Achilles tendon, giving a posterior acoustic shadow, and nothing much could be seen due to the tophus. Here is your Achilles tendon. Looks like the Achilles tendon is torn, but no, this is just a shadow from that deep, thick tophus, and the Achilles tendon cannot be viewed deep to that tophus. And here is another image of an Achilles tendon at the attachment, looking at the calcification at the attachment of the Achilles tendon, the so-called calcaneal spurs. This long axis view of the tendon, and here is your short axis view of the same tendon. Here is another patient with pain and swelling on the posterior aspect of the left ankle. On a clinical examination, noted to be a huge swelling of the Achilles tendon as compared to the right ankle. Now, the sonographic examination showed a thickening and a widening of the Achilles tendon proximal to the attachment to the calcaneus, and the tendon is also hypoechoic, anechoic if you're looking at it. And here is a short axis view of the same tendon consistent with Achilles tendinopathy. Here is another patient who came with a pain and swelling on the posterior aspect of the ankle. The sonographic examination showed a normal appearing Achilles tendon. Here is the starting of the Achilles tendon and going across, and here is the short axis view of the Achilles tendon. But the appearance, the cobblestone appearance of the Kager's fat pad was consistent with the cellulitis in the Kager's fat pad. Here is another patient who came with pain and swelling on the posterior aspect of the ankle and was noted to have tenderness at the attachment of the Achilles tendon and anterior to the Achilles tendon. The sonographic examination showed the hypoechoic widening of the retrocalcaneal bursa consistent with retrocalcaneal bursitis. The retrocalcaneal bursa is a coma-shaped structure deep to the Achilles tendon, between the Achilles tendon and the superior aspect of the calcaneus. Here are some images of patients with pain and swelling of the MTP joints indicative of gout. What you see here, there is a deposition of a layer of uric crystals on the cartilage surface, and on the ultrasound image we call it a double contour sign, which is about 90% specific for the diagnosis of gout. Here are some other images of the tophaceous deposits, some soft, some hard. Here is a hard deposit with posterior acoustic shadow. Here is another phase of gout with tophaceous deposits and multiple erosions on the MTP joint of multiple patients. Now, this patient had a large fluctuant swelling of his first MTP joint with snowstorm-like crystal deposits in the MTP joint. 5 ml of purulent material was aspirated. The examination of the fluid under polarized light microscope showed no cells but all crystals and negative cultures. The synovial lining of the MTP joint is reflected proximal to the metatarsal head, which is the site of accumulation of fluid during the MTP joint pathologies associated with joint effusion. Here is the long axis view of the first MTP joint, and here is the short axis. What you see here is the extension of the recess proximal to the metatarsal head. As always stated, the scanning should always be done in long axis and in short axis. Here is this big osteophyte on the metatarsal head in the long axis scan, which gives an appearance of a free floating foreign body in the MTP joint space on the short axis scan. This patient was sent to me for evaluation of first MTP gout, which was getting worse despite the adequate dose of indomethacin and colchicine for treatment of gout. The sonographic examination of the MTP joint showed a normal MTP but markedly hyperechoic subcutaneous fat with hypoechoic septa indicative of subcutaneous edema. Patient responded very well to the treatment for cellulitis with amoxicillin and clavulanic acid. This is a patient with severe pain and tenderness at the bottom of her heel. The sonography showed markedly thick and hypoechoic hypoechoic plantar fascia at the attachment of the calcaneus. She responded very well to the glucocorticoid injection and percutaneous needling of the plantar fascia.